Okay, let's talk about a really tough situation. Imagine your knee is severely damaged. I mean, the whole alignment of your leg is off. A critical piece of cartilage has been ripped clean off the bone, and arthritis is basically moving in. You and your surgeon have a huge decision to make. So let's get into it because a major new analysis has just come out with some truly surprising answers. It really boils down to this one simple question. When you're dealing with a complex knee problem like this, is the answer always to throw more surgery at it, to fix every single little thing you can see? Or is it possible that a simpler, more focused approach could be just as good, maybe even better? That's exactly what we're going to explore. All right, so let's break this problem down, piece by piece. First up is the alignment issue. Now, surgeons call this a varus knee, but for you and me, let's just think of it as being bow-legged. What this does is it shifts your body's weight, and it concentrates all of that force right on the inside part of the knee. It just overloads that one spot with every single step. Now, here's the second part of this nasty combination. Your meniscus. That's the C-shaped shock absorber in your knee. Well, in this specific injury, the very root of that shock absorber gets torn clean off the bone. Think of it like a tire on your car just blowing out. In an instant, it completely loses its ability to spread out the forces, so all that impact just hammers down on one unprotected spot of cartilage. And here's the thing. These two problems, they don't just exist next to each other. Oh no. They actually feed on each other. They create this destructive, vicious cycle right inside the knee joint. And this is absolutely the key point. The bow-legged alignment is already putting way too much force on the inside of the knee. And now the shock absorber on that exact same side has totally failed. It's a double whammy. It's not just a simple injury anymore. It's a full-on biomechanical crisis that causes cartilage to wear away at a scary pace, basically fast-tracking that knee towards severe arthritis. So a surgeon looks at this and sees two main options for how to fix it. And that's where this new analysis comes in. It set out to finally figure out which of these two surgeries actually gives patients the best results. And let's be clear, this wasn't just some quick look at the research. This was a massive deep dive. Scientists sifted through hundreds and hundreds of studies to find only the absolute best, most high-quality evidence. They ended up pooling the data from 13 different studies, which included a total of 725 patients. This gives us a really powerful, high-definition picture of what's going on. Okay, so both surgical options start with the same procedure. It's called a high tibial osteotomy, or HTO. Just think of it like some really clever carpentry for your shin bone. A surgeon makes a very precise cut, opens up a little wedge to straighten out the leg, and then locks it all in place with a plate and screws. The whole point is to realign your leg to shift your body weight off that damaged inner part of the knee. And this brings us right to the heart of the debate. Option 1. A surgeon performs the HTO to fix the alignment, and that's it. Let the pressure relief do its magic. Or option 2, the surgeon does the HTO and goes the extra step of surgically reattaching that torn meniscus root back to the bone. Basically, do you fix just one problem or do you try to fix both at the same time? That is the big question. All right, let's get to the results. We'll start with what is arguably the most important question of all. After all this, how did the patients themselves actually feel? Well, the study's conclusion here is about as clear as it gets. The combined surgery, the one where they fix both the alignment and the meniscus, it led to way better outcomes, as reported by the patients themselves. And we're not talking about a tiny difference here. This was a real, meaningful improvement in their ability to function day to day. Now check this out. This chart is called a forest plot, and it tells the story so well. All you need to know is, if that little diamond is to the right of the center line, it means the combined surgery was better. And for the HSS score, which is a huge measure of pain and function, look at that diamond. It is sitting way, way over on the right. Statistically, that's a slam dunk, a clear, undeniable win for doing the extra repair. And this wasn't just a fluke. Across a bunch of different scoring systems, the result was the same. Patients who got both the alignment fixed and the meniscus repaired just did better. Less pain, better function, and crucially, the improvement was so big that it crossed this scientific line called the minimal clinically important difference. That's just a fancy way of saying the benefit wasn't just a number on a page, it was a real-world change that people could actually feel in their lives. So, case closed, right? More surgery is definitely better. Well, not so fast. This is where the story takes a really fascinating and, honestly, unexpected turn. Let's take a look inside the knee itself. Because here's the thing, even though the patients who got the extra meniscus repair felt so much better, when the doctors actually looked at their follow-up x-rays and MRIs, they found something truly bizarre. And this chart just illustrates the puzzle perfectly. It's another one of those forest plots. Remember how the last one had the diamond way off to the right? A clear winner? Well, look at this one. This is for something called meniscal extrusion, a key sign of stress in the joint. This time, the diamond is sitting dead center, smack dab on that middle no effect line. That means, statistically speaking, there was zero difference between the two groups. The extra repair didn't seem to change a single thing on the MRI. And it wasn't just that one measurement. In the short term, there were no significant differences in how fast arthritis was progressing, or in the width of the joint space, nothing. So now we've got this incredible paradox. The patients feel much, much better, but their x-rays look pretty much the same, no matter which surgery they had. So what gives? How in the world do we solve this? How can people feel so much better if their scans don't actually look any better? What is the final verdict here? Well, a clue might be in the healing process itself. In some of these studies, surgeons actually went back in with a tiny camera for a second look. And what they found was that only about a third, just 33% of the repaired meniscus had what they'd call complete healing. This kind of suggests that the huge benefit patients are feeling might not be coming from a perfect textbook anatomical fix. So here it is. This is the core paradox of the whole analysis, laid out as simply as possible. On one side, you have patient-reported outcomes, how they feel, how they function, dramatically better with the combined surgery. But on the other side, you have the short-term changes you can actually see on an X-ray or MRI, and they're basically the same. So the bottom line is this. Doing that extra meniscus repair provides a real, tangible, important benefit to a patient's quality of life. That much is crystal clear. But we have to be real about the limitations here. The average follow-up was only about 2 years. It's totally possible that the benefits on X-ray just take longer to show up. We really need longer-term studies to know for sure. And that leaves us with this final, fascinating question. For the long-term health of a knee, which is actually more important? Is it the patient's immediate experience, less pain, better function? Or is it the structural changes that we can measure on an X-ray? This study suggests the answer might be a whole lot more complicated than we ever thought.